All right, hello everyone. Welcome to this very early morning for those of us who work nights exclusively. But welcome to our didactic Words Matter, Ableism terminology, and their impact on the care of patients with disabilities. We're just gonna, since there's a big group of us that helped put this together, we're just gonna introduce ourselves briefly. I'm Dr. Anika Backster. I'm with Emory University.
I'm Rotoli with the University of Rochester.
Cori Poffenberger, University of New Mexico.
I'm Cullan. I'm from University of Rochester.
I'm Kamna S. I'm at Hopkins. Payal Modi, I'm the UMass Lister.
I'm Katrina Gipson, and I'm also at Emory.
So very exciting. Honestly, having so many people come together from all over the U.S., I think really speaks volumes to this growing awareness. And again, thank you all for coming, because hopefully you'll take this back to your home institutions and sort of start a discussion and work on how to help accommodate your patients and colleagues sometimes. We have no disclosures. Our learning objectives are to help you recognize disability as an aspect of diversity, have you understand ableism and understand what outdated disability language is, demonstrate the implications and impact of ableist language on healthcare access to the disability community, and have you start to understand and be able to apply best practices in language and communication to clinical practice in order to navigate bias and ableism.
Okay, so wanted to do a little bit of background about why we're speaking about this today. So unfortunately, people with disabilities are an often unrecognized healthcare disparity population. They experience substantial barriers toward accessing healthcare. And there are many aspects that go into constructing those barriers, including things like provider lack of knowledge, stereotypes about disabilities, as well as specific physical or procedural barriers in terms of the policies that are created, the way that buildings are constructed for people with physical disabilities, the way we communicate, and how people can access information about healthcare. And underlying all of this is really what we're talking about today, which is ableism. And so we wanted to make you aware of these barriers so that you can think about the way in which the language that we use might help to either reinforce or deconstruct those barriers.
So that brings us to the question. That brings us to the question of what is ableism, and it's really important to have an idea in our minds about what this means. So ableism is defined as practices or policies or the belief that those with disabilities are somehow less. So it's the sort of assumption that able-bodiedness is the default state and that anything different from that is in some way less, that people with disabilities are invisible, disposable, and that we're taking for granted those who are able-bodied. And so ableism incorporates certain assumptions about people with disabilities. So existing literature indicates that people who are able-bodied tend very frequently to mischaracterize the quality of life of those with disabilities. And most clinicians are able-bodied, and so most clinicians are at risk of making assumptions about the quality of life of those with disabilities. And oftentimes this assumption is that those with disabilities have a poorer quality of life. And disability often gets conflated with suffering or pain, which isn't always accurate. The experience of being disabled can be varied, and disability does not mean disease. And so today we're really going to address sort of one aspect of how clinicians can be advocates for those with disabilities, something that we can all actively work on, which is language. So our misconceptions about patients with disabilities not only impact our communication with patients with disabilities and impact individual health outcomes through miscommunication, but as clinicians, the tone we set can also impact health policy, can also impact interpersonal discrimination and stigma. So it's really incumbent upon us to come to the table with humility to try to understand the ways in which language can be applied appropriately to mitigate bias and to mitigate ableism.
So this is by no means an all-encompassing list, but it does provide some examples of terminology that is on the right-hand side of the table considered to be outdated and archaic and portrays a negative connotation whenever it is used compared to some of the more updated terms on the left side. And the other thing that you'll notice the terms on the left side is that they are descriptive without being pejorative. And so if I go through some of these examples, if you're talking about somebody with hearing loss, the preferred terms are going to be deaf or hard of hearing or simply hearing loss. If you're talking about somebody with vision loss, it is okay to say blind or a person with low vision. Cori and I love this example. The word handicap is actually a noun. It is not an adjective. And I think all of us would agree that a parking space actually is providing access and does not in fact have a handicap. So accessible parking is really the term that makes sense in that situation. High and low functioning really gives you no idea of what the person is able to do, and so it is just easier and makes more sense to describe what kind of things they are able to do at home, and it gives you as a provider an idea of what kind of accommodations they may need in the ED or upon discharge. Victim or afflicted by, again, these are not people who are suffering. We should make no assumptions about their quality of life, and so it is a person with X disability. Cripple and spastic, retarded, invalid, again, they don't give you any information and they do portray this negative connotation. So, excuse me, so intellectual disability is the preferred term. And the last one is a really common example. People are not chained and strapped to their wheelchairs or to a bed. People use wheelchairs for mobility. I think Cori often gives the example, people with glasses use glasses to improve their vision. I don't think you would ever say that somebody is glasses bound. They have glasses to improve their vision.
So we also wanted to talk a little bit about some ableist microaggressions, and this list is fairly extensive, and I think some of these things you might look at them and think, okay, yeah, that's clear, that's inappropriate to say. Some of these things I think are so commonly used that it doesn't register for us that it could be a microaggression. And that's the thing about microaggressions, right? Is that unless you're a member of the group, you might not appreciate that it is offensive or upsetting when you say these things. So just these are everyday verbal or behavioral expressions that communicate a negative slight or an insult in relation to specifically disability in this case. So things like, that's so lame. I think we all are familiar with not using the term retarded. You are so retarded. That guy is crazy. I've been trying to move crazy out of my vocabulary a bit and use other terms like wild or exciting or whatever, something more descriptive anyway. Things like, you're acting so bipolar today, or I feel so ADHD today, or I'm super OCD about how I clean my apartment. If you don't carry those diagnoses, that can be a microaggression toward those groups. Things like, can I pray for you, or I don't even think of you as disabled, obviously portray a very negative attitude toward the idea of disability in general and just should be avoided. And then there's some of those other things like, it's like the blind leading the blind, or my ideas fell on deaf ears. Again, some members of those groups might not find those terms offensive, but I think it's important for us to be aware that it might be upsetting to some members.
I'll just add that last one. I think you can apply that to any marginalized group. Like, I don't even think of you as gay. I don't even think of you as deaf. I don't even think of you as whatever. But I am. I am.
And so the other part about language, and Jason kind of alluded to this a bit, is this idea of person-first language versus identity-first language. And so if you read in a textbook, they often say, use person-first language, which really emphasizes the person before the disability or identity. So you would say person with a disability, or you would say person who is blind, person who uses a wheelchair. It's used often in formal teaching and writing, but may not be the preference of an individual. In recent years, a lot of members of the disability community have felt like it doesn't adequately describe them, and they prefer identity-first language, which really puts disability first, and it's the idea that their disability is part of who they are, not something that they have. And so examples would be a disabled person, an autistic person, a deaf person. is often preferred by the deaf and autistic communities, but there may be others as well. So it's best if you just talk to people and ask what they prefer.
All right. I'm not sure this is on. Oh, it wasn't. There we go. Okay, so being able to take things from the actual emergency department, working healthcare in general, it's important that we emphasize these aspects of we can't just go based on someone's identity, but going forward and being able to look at the actual individual person. Even within these subgroups, there is individuality through that, and there are a lot of things that to keep in mind when we're actually interacting with these patients. Okay, sorry. So in general, no matter if someone is within a certain group or identity, it's always good to first introduce yourself and any other people that are within the room. Always make eye contact, and it's always best to kind of make yourself down to the patient's level, not to assert any kind of power dynamic, or just kind of identifying yourself as another human being that's trying to help take care of them. It's always good to ask people's preferences, whether they have certain ways they want to communicate or certain other pronouns and things of that nature. And always ask who the other people are in the room. I'm sure we've all had experiences where we just kind of created this thought of, well, this is probably their husband or their wife. Turns out to be like a family member instead. So it's good to kind of clarify those things and not make assumptions based on the people around us. It's always good to speak at a normal rate, tone, and volume. I know that masks have made that hard, and I feel like I've gotten better with actually speaking because of the masks, because I try not to mumble. And I think it's always good to try and match your health literacy to the people that you're with. It's important to be able to, give a layman's terms to people that don't really have a lot of health literacy. But if someone easily identifies themselves like a nurse or another healthcare worker, sometimes it's a little better to actually be able to describe those terms because they're likely more familiar with them. And it's always important to allow time. I know that the emergency department itself is a very fast-paced place, but a lot of it's important to not lose sight of the actual humanity and making sure people feel like they're being heard or communicated with when they're actually interacting with us. So to go a little bit more specifically for people that have blindness or vision loss, it's important to introduce yourself each time you enter the room. For obvious reasons, we need to be able to identify either myself or someone else that came into the room with me, making sure that they know what my role is. It's also important to let them know when you're leaving. If they have further questions and don't realize that you'd already left the room, that can be quite distressing. It is always important to be very specific and descriptive when communicating with people. If you're trying to point at something, or it's important to actually be able to kind of change how you're doing things based on what would be most accommodating for them. And it always inform the patient before you start your physical exam. And one of the reasons why I put in this photo here is because I'm sure we've all had scenarios where we've kind of just quickly gone into a patient's room to grab something, or if there's something in a drawer. If someone were to be blind or visually impaired, if you go in there and start rummaging through a shelf or something like that, that can be quite distressing, especially if they don't think that that's actually something for them or for someone else, or they have no idea who's essentially in the room. So for people that cannot communicate intentionally, it's some people with severe intellectual disability may not be able to understand verbal or other types of communication. They may be able to communicate through their experience or either internal or external stimuli, through changes in their facial expressions, the way they move their body. And this may be an instance where we rely on people that are very knowledgeable of that patient themselves, whether it's a family member or someone from the home they live in, because there may be ways that they communicate certain things that we would have no idea about. But if they have certain ways that they generally communicate pain, or whether they do or do not want something, those are things that people that have greater experience with that patient would be able to provide for us. So with people with intellectual disability, always address the patient directly, and do not try to infantize a person, especially if they're an adult. Make them them an active member of the actual conversation itself, and I try to avoid keeping them from feeling like they're not an active participant in their own healthcare. Obviously, intellectual disability is a wide spectrum, but it's always important to make sure that the patient is first and foremost your main priority. What is very helpful is to use an appropriate tone of voice. Like I was saying, speak to them like they're an adult. And generally, I know a lot of patients, when they come from places like group homes or long-term care facilities, they very often present with an actual, like a binder, a plan of care, and that can be incredibly helpful, especially if there's a worker with them to kind of maybe see what their common chief complaints are, or be able to understand if there are specific ways of interacting with the patients, or if there are certain things to avoid. That information generally comes with them. Another thing to kind of consider is how we do the actual communication itself. Receptive communication is essentially allowing the patient to have actual time to process what you're saying and how you're saying it. It's important to speak slowly and be there for them to actually have time to process the words, take your time, speak very clearly and with clear intentions, and be able to provide time for them to answer as well, especially if they're not feeling like they're actually getting their complaints out. It's not going to be helpful for them. Another thing is expressive communication. Whether if it's someone that would be assisted by you being able to point or draw something, or be able to actually physically pantomime what you're trying to describe, or show them what action you want them to do prior to them actually doing it. Those things can be very helpful for them. And another thing to consider is if a patient has an alternative communication device. AACs are typically used in people with neuromuscular disorders and things of that nature, and they can be very helpful, and sometimes patients will present with them. Another nice side note is that if a patient is having trouble with their actual AAC device, it's very common that speech-language pathologists within the hospital are able to recalibrate them.
So on this slide, there are two different groups of people that I just want to talk about briefly, but then we will hear from some of our experts a little bit later. The first group is the deaf or hard of hearing group, who belong to a group of people who use American Sign Language as their primary language. They share a common identity, they share common life experiences, and do not identify as hearing impaired. And with this group, the gold standard when communicating with them is to have an in-person ASL interpreter. I recognize that is unique to certain areas of the country. I'm very lucky where we are. We have wonderful interpreters. Obviously here in Austin we do as well. But that may not always be available, and so in that situation you can think about using the VRI or interpreter in the iPad. I think interpreter is still the gold standard, and if you have the ability to in person, that is best. You have to position yourself so that everyone can be seen during the encounter. And you want to think visually and you want to act visually. And so that means using pictures, it means using your body, it means showing the patient's images or their images so that you can sort of draw a picture of what you're trying to communicate. If all of that fails, if you don't have access to technology, you don't have access to an interpreter, you can use written English, keeping in mind that this is a second language most of the time for our ASL users. And so the English needs to be somewhat simplified to match the patient's literacy level, sometimes, depending on where you are. But it also needs to be free of medical jargon. And I think that's a good tip for any patient. And then the second group is our oral hearing community, our oral deaf community. And I put the word impaired on there for a second. I'll talk about that. But this is a group of people who do use speech and lip reading and things like real-time translation. We always have closed captioning in our presentations, and as you noticed, we do not have them set up here, but that is a problem with the technology that we are still struggling with to try to break through. Even though we had this didactic plan and accepted, we still couldn't have all the accommodations that we normally use. And so we had to make some last-minute adjustments with this little laptop here, but we are trying our best. You can use written text. Again, think visually, use pictures, use your body to show the patient what you're talking about. And in this last line here, I think is maybe where the term impaired is okay. I think if you think about our parents or grandparents, who grew up hearing and with a verbal language, they probably do feel impaired by their hearing loss. And so these people have presbycusis, and I think you can safely use that term with that population, but in that situation, you should use a lower tone of voice, maybe speak a little bit louder and a little bit slower.
So last kind of area, I think, for best practices in communication is when working with people with physical disability. Obviously, specific to physical disability, there isn't necessarily a communication challenge per se, but for someone, for example, who uses a wheelchair, I think it's helpful if you put yourself at their level, at their eye level, so you're not kind of standing over them and talking to them, but sit down so that you can have a conversation at eye level. Of course, like with any patient, ideally we would ask what accommodations the patient needs to be comfortable at the visit. Never lean on a wheelchair or other assistive device. You should consider that part of someone's body. So I wouldn't go up to Jason and just like put my arm on him and be like, how's it going? Or maybe I would, I don't know, we're friends. Don't, put your coat on the back of the wheelchair to just, have a convenient place to store it. Never physically move a wheelchair or an assistive device. Again, that's part of someone's body, so don't just go up and like physically relocate someone because they're in your way. You could just, ask them to move. And then ideally, we would always ensure the space in which we are communicating is fully physically accessible for someone who might use alternate methods of mobility. And then finally, if you offer assistance, always wait until the patient or person you're offering assistance to says yes. Maybe they don't want you to open the door for them. They would prefer to open the door themselves. So just don't make any assumptions about what a person might need, but rather listen to them, take their cues in terms of offering assistance.
All right, so we have a couple of brief videos just to kind of switch things up. This first video, if you're on Instagram, Caitlin Partlow, she's wonderful. She's autistic and she's an advocate and she's a wonderful speaker. And if you're interested in learning more about autism, what it's like from someone in the first, who's very practice at doing this, and this is her passion. She's fantastic. So check her out. Just get this to play.
People might say that being politically correct is more important now than ever before. Some might be afraid to speak on certain topics for fear of offending someone. The autism community has made several shifts in how we talk about things over the last few years. This leaves many parents and professionals confused about what language is acceptable and what language is not. But here's the thing, no matter where you fit in the autism community, you don't need to be perfect, and you don't need to always use all the right words. When you know better, you do better. If you remain open to knowing better, you don't need to beat yourself up over not doing better before you knew. If you're ever unsure of the best way to refer to someone or something that is autism related, there are several online resources to provide insight on those topics. And that's the polite way of saying Google it. I would also encourage you to seek out information from autistic advocates who have experience working in an autism-related field. Yes, language matters, but when we know better, we do better, and that is one of the many reasons why I continue to advocate.
She's very approachable also, by the way. I've sent her Instagram text, and she gave me permission to use her video. She's really cool. Let's try to get this. Do you want to introduce before or after?
Yeah. So these are a couple videos that I made with the help of a couple patient advocates who feel very strongly about education about disability, and just kind of, they're maybe a little on the nose, but just kind of showing some examples of things we might do in our everyday practice that are inappropriate and can be improved upon. I think when you watch them, you'll identify the challenges.
So we're going to do an exam. I need to move you over here a little bit.
Okay.
Let me make this thing work. Okay.
Yeah.
All right. So I'm going to listen to your...
Yeah. Always. Well. Yeah, because it won't. It
So,
brings up
sorry,
a second window.
in one of the videos that you were just hearing, I am a healthcare provider, and I'm trying to perform a physical exam on my friend Christine here, who uses a wheelchair, and rather than asking her to move, I just, move her wheelchair out of the way for her. And then I I think I use the term wheelchair bound and a few other inappropriate terms in that conversation. And then there's another video where my friend Cheryl, who has cerebral palsy, I make some inappropriate assumptions about who's with her at her healthcare visit and start speaking to the person who brought her, who is actually not her, healthcare, anyone really related to her at all, just like drove her to the appointment. And she's fully able to, interact and provide all of her own healthcare information.
Let's see if this one.
Hi, Mr. Nutt. I'm Dr. Rotoli. What can I do for you today? Oh, is he deaf? Oh, okay. You know what? I'll just slide you down a little bit. I'm Dr. Rotoli. What can I do for you today?
You could, look at the interpreter and use the interpreter for our interaction.
Do you read lips?
A little bit, but
Okay.
really we can communicate through the interpreter directly.
I think if he probably understands me, he could probably read my lips.
So I've shared
Hi,
this
Mr. Nutt. I'm Dr. Rotoli. What can I do for you
I'm
today?
going to share it again. So I've shared this video several times. I think my interns have seen it, and it is intentionally ridiculous. But it really gets the point across that I am really pushing my comfort of language and being ableist and even autist, if you will, onto the patient. And they have essentially given me the opportunity to build a bridge. They've given me their language preference. The interpreter is already set in place. And I've gone and basically just destroyed that opportunity and ignored them. And although this is not terminology related, it is certainly interpersonal related and I think very common. So being very careful of your actions is really the intention of this video.
So we're going to transition a little bit, and we have a excellent panelist of speakers today. So I wanted to give them a moment to introduce themselves and share a little bit about themselves before we get started. So, whoever wants to start.
I'll start. Hi, good morning. My name is Chris Moreland. I'm an internist, a hospitalist. I work just upstairs at the other end of the phone call line. I live vicariously in your profession through my wife, who is also an emergency medicine physician. I'm deaf. I speak for myself, and I also use sign language. Today I'm working with an interpreter. I work currently here in Austin at Dell Medical School. I'm an associate professor in APD with our residency program, and I'm currently the interim chair of hospital medicine. So that's me.
I'm Cullan. I'm a first-year emergency medicine resident at the University of Rochester. I was born and raised in Buffalo, New York. I have some interest in sports medicine, luckily after residency as well. And I've been really enjoying Austin so far.
Hey, I'm Alex Schneider. I'm a software engineer. I work on computers documents. But my primary role is incident management and disaster recovery for computers. So I kind of live a little bit vicariously through emergency medicine in that way. I'm oral deaf, and I typically with reading and whatever the children may have, as well as a card that we mentioned earlier in the presentation.
Hi again. So I'm Cori Poffenberger. I am, as I said earlier, a faculty member in emergency medicine at the University of New Mexico. I personally do not have a disability. disability, but my daughter has a physical disability, and that's how I got involved in the space. So I consider myself a disability adjacent or disability advocate, and I'm happy to share my experiences with you.
Thank you so much for coming in today. I guess to start off, so we will be soliciting questions from the group. So if you have one, please raise your hand and I will call on you after, whichever panelist speaks. To start off, what is the, best way to ask a person what terminology they prefer when you walk into a room or as a patient? And can you move the mic a little bit closer to your mouth? Thank you.
For me, it always works best if the doctor that I'm talking to or the person I'm talking to just asks outright up front, maybe before I see them at the front desk if that's possible, but the first interaction, if they ask what terminology I prefer, that's always a good sign here. The interaction is generally going to go pretty well.
Anyone? Okay. And as some of the clinicians in the room, when you kind of enter a patient's room, what is your typical introduction and how do you typically greet the patients when you encounter them?
So I very frequently, I try to be as kind of relaxed as possible. I will always try to see what they would prefer their name to be called as well, whether they want their first or last name. I very frequently, if we have kind of smaller hospital rooms currently, but I generally, if there isn't a chair for me to sit in, I will generally try to kneel down and be eye level with the patient, and that's when I'll kind of initiate those conversations with, is there a preferred way that you'd like me to address you, going based on that.
I take a similar strategy as Cullan. I think typically, I'm deaf. I work with interpreters primarily at the hospital. I think when I started as a third-year med student in my clerkship, the first time that I ever met a patient there, I went into the room and I just thought that I was going to introduce myself using spoken English. I didn't mention that I was using interpreters, and it became awkward. So then the next time, I tried a different approach. I introduced myself. I said, I'm deaf. These are my interpreters. I explained their role, which took quite a while. And that was also a little bit awkward. So then after that, I realized I was worried too much about explaining myself, my deafness, my use of interpreters, when I could just focus on the patient. And that has been my approach up to this point. I introduce myself, my name first, my first name, my last name, and I read the room. Oftentimes I'll say I'm deaf, the interpreter's with me, and then I'll just launch into whatever we do. And as Cullan said, I will just maybe ask, what's your name? And just try to set up a good rapport and meet them at their level.
Yeah.
So I think that's about it.
And so I think this kind of segues as you start getting information from the patient. What are some of the best practices in balancing information from a patient and a healthcare advocate that might be in the room?
Also, with my own personal experience, kind of like what we talked about in the actual presentation, is still making the patient focus of the actual interview itself. But also, if it's a situation where I'm going to primarily get most of the information from their advocate, maintaining that relationship and making sure that they see that I genuinely do care for the person that we're taking care of, showing concern, and something that a mentor of mine from medical school actually will do. He's a pediatrician. He works primarily with people with neuromuscular disabilities. He would actually ask the parents, with these long-term ill children, he'd ask them to say one amazing thing about their kid, just to kind of change the perspective what the actual interview is going to be, and making that connection, making sure that the advocate or parent in that situation knows that he really does care for that person beyond their illness.
That's a great tip. Anything?
Yeah, I agree completely. And I think, when you think of, typically even in emergency medicine, we're looking at the chart before we go see the patient. right? So you have some idea of their, prior visits, and, hopefully if the EMR system's working for you, they might give you some idea of what their communication needs are, or their communication preferences, what accommodations they might need. Sometimes you don't have all of that. Sometimes you're just going in blind, they're new to your system, or it's a real emergency, or whatever the reason. So I agree with engaging with the patient, introducing yourself, finding out who's in the room, not making any assumptions or errors in terms of what these people might be, what the patient's ability is to communicate, and really taking the cue from both the patient and potentially the family, depending on the particular situation, as to how they would like the interaction to go, and how they would like to communicate. And as Paul said, never forgetting that the patient is still your primary responsibility.
And Alex, what are some things that immediately help you build rapport if you've been a patient, or helps you feel like the clinician is open to you and willing to understand you?
I think that the clinician just kind of meeting me on my level and understanding what my needs are and what my communication my communication abilities are, and understanding what the actual disability I have is, the communication disability. I have trouble hearing them. I have trouble understanding. I have trouble understanding their speech, but I don't have trouble comprehending what they're saying. So
Right.
they're sort of reducing the complexity of what they're saying, and that kind of hurts that rapport and that interaction. I'm sure there's plenty of other things, but just treating me like a person who has a disability rather than the disability being the person why I'm here.
Thank you. And I wanted to kind of open up to see if anybody had any questions from the room that have come up, or I can keep. Yeah, go ahead. One second.
Testing. How are you able to, this might be a hard question, so I apologize in advance, but as a parent and advocate, how do you strike a balance where you are able to set your child up for success without infantilizing or setting them up to fail, if that makes sense?
No, it definitely makes sense. It's a good question. I don't know that I have all the answers yet. I'm still kind of figuring out as we go. But I would say, we try really hard to, first of all, set up the environment for success for her, so that we put her in places where she can have the maximum amount of independence possible in a safe way. She's a full-time wheelchair user, and so there are a lot of spaces we go into where we're like, oh, we can't even navigate this space, or it's not really a space that works for us. And when she was little, it was easy because you could just pick her up and carry her around. But obviously, she's 10 now, she doesn't really want us to do that. And so it requires a lot of thought and planning in terms of that. And then, I'm learning to just, listen to her. We go to doctor's appointments now, and she wants to be the one who is giving all of her information and, talking about it. And we're working on, managing her medications and, all of those things. So, I definitely am not perfect at it. Like anything, I fail and we figure it out again. But we just do our best, and I try to take my cues from her. I think sometimes it's challenging in the healthcare setting, being in healthcare myself, when I'm interacting with her healthcare providers, because I never really know which hat to wear sometimes. And I try to, just be mom, but obviously having the knowledge we have makes that challenging at times. But it also, I think, gives me a lot of advantages in terms of helping her get what she needs. So pluses and minuses.
Thank you. I think that those points are really helpful. I think that, Cori talks about how she enables an environment for her daughter. And I think as a clinician, we also need to remember how we can enable an environment for our patients. If someone is hard of hearing, we can close the door to make things easier to hear, for example. And so it's also trying to build those practices into your day-to-day, like knocking on a door or, announcing yourself when you tell them who you are when you walk in the room. So, that way, even if you don't know if they're hard of hearing, if they happen to be, or if they happen to be visual, have a visual disability, they can know that you're there. And so you're just kind of building these best practices in for everybody if it's not announced beforehand. So are there any other, I just threw a couple things out there, but are there any other things that you guys routinely do or have noticed have helped you and kind of have best practices in every kind of encounter with your patients if you don't know?
Yeah, I like to build off what Cori was mentioning. As I mentioned, I am a parent myself, and a lot of what she said also resonates with me. I think that a lot of what she has talked about as a parent works as a provider or as a healthcare professional in the room also. Just ask open-ended questions. I try to do that as much as possible with my patients, with my students as well, my team members. Just ask, what do you need? Are we good before we start the direction in which we would like to go? And then, of course, sometimes we are pressed for time, and so you can just, ask that for a few seconds, take a moment to check in, and then it's kind of like a procedural tap out, and then you can move on to the communication, timeout, and then the communication timeout. And so I have found that sets a nice tone for a therapeutic relationship, and then also helps me understand what's actually going on with them. And I also like to approach it through the frame of cultural humility. I don't have a lot of knowledge about the person in front of me, their network, and those that they love, and who's in the room with them.
One thing I wanted to mention in that regard is that I'm fortunate enough not to be a frequent flyer in the emergency room, but when I have been there, it's a very foreign environment for me as a patient. And I've noticed friends who have disabilities have a lot of difficulty understanding what they need. And one thing that really helped in some cases, and would have really helped in other cases, would have been having a solution that the patient, the doctor came prepared with. You can find the best solution. Because the patient may not be, they're in a really high stress environment, they're not really sure what the right thing to do is, and it can be very difficult for them to advocate for themselves without you creating the space for them to do that.
I think I saw a question in the back somewhere.
I was trying to hear.
Okay.
You're not speaking loud enough.
Just if we can put the mic a little bit closer to your mouth, but thank you, that's okay.
And I have a couple of comments, if I may.
Sure.
I am the mother of a handicapped child. Except that he's not a child, he's 43. I can use the microphone or I can project. All right. So I'm the mother of a handicapped child, and I'm his advocate, but he's also mentally handicapped, so although he does understand a fair amount, he certainly doesn't understand some of the nitty-gritty of medical discussion, which my parents or husband wouldn't either. I also speak a number of languages, so I've done some interpreting. And one thing that I've always tried to do is to speak directly to the person that I am speaking to, even if I'm being a simultaneous translator. I kind of just stare off into space and let it go in one ear and out the mouth. But when I'm using a translator, I try to speak in very short sentences, because I know that it's hard to take a whole paragraph of medical information, turn it down into the other language at a level that the patient can understand. It just gets difficult. Those are just the comments I wanted to make. Sorry for taking up your time.
No, thank you.
Hi, my name is John DeAngelis. I'm from the University of Rochester. So I wanted to open a question up to the whole panel. So right now, emergency departments in general, especially ours, are a little beleaguered. And I spend probably half of my shift apologizing for to everybody, all comers, for the wait, the chair in the hallway, we ran out of turkey sandwiches again, et cetera, et cetera, et cetera. I was wondering if the panel could address are there best ways, or are there ways to address when accommodations simply don't exist, and how to possibly overcome that or apologize for that, or how to address that? Thank you.
What I've personally kind of found in these situations, especially given how limited a lot of our resources are, whether it's just part of the hospital's issue. Sorry. So something that I've been using just to kind of help make up for the fact that we do have a lot of limitations and lack of resources. And when it's appropriate, I personally turn to humor. I find that's a really good way of connecting with patients sometimes, and it shows them that I think that these situations are absurd as well sometimes. And so we can at least relate on that level, because we're not going to be able to fix it from one complaint or one kind of situation like that. So I personally, with even just in general with patient interactions, will turn to humor.
For me, what I try to do and what I appreciate being done is creativity. You may not have the accommodation that is best practice or that the patient is asking for, but if you can find something, anything that works for them, and just even if it's like as a deaf person, even if it's as simple as taking an extra 5 minutes with the patient, writing down on paper, getting an iPad, typing down on it, then that just goes so far compared to just to throw it out your hands and say, I can't do anything. And the other thing would be that following up after the visit, if there was some deficiency, finding out who can correct that, connecting the patient to that person, working with whatever possible resources we have to correct that goes a long way, because maybe you can't help that patient, you can help the next patient, you can help that patient next time they come in. That's good.
Yeah, I couldn't agree more with Alex. I think we always, I think this is true for like all aspects of care for all of our patients, but we tend to be like, oh, we do this way, and we can't do it that way. Why can't we do it that way? Nobody really knows, just because we aren't used to it or we can't think of it. And so, maybe you don't have the best practice accommodation, but, the patient is an expert on their condition, right? So I was going to be like, well, we can't do that, so what do you think we should do? Here's our options. Let's brainstorm together. And then the patient it's patient-centered, they have some role. And, people with disabilities, unfortunately, due to our lack of accommodating in our society, are very used to having to do this. And they may have a lot of ideas that could be helpful that you won't think of because you're not the expert on their condition. So I would say in general, in your encounters with people with disabilities, use their expertise in their condition and allow them to help guide you in what might be possible, and just maintain that flexibility of mind that, you don't have to do things a certain way.
And if I may, started to take the microphone, I don't need it. Yeah, I couldn't agree more with everything that's already been said by the other panelists. So just to ask somebody, what ideas do you have? If you ask that question, you're going to be one of the few physicians that do ask, because most don't. And I'm going to pivot to my experience as a patient, as a deaf patient. And the parent, a deaf parent of a daughter. I had a daughter that was in the NICU, and every morning on rounds, the physicians would speak to my wife and I and have this grand discussion and try to answer questions that we had. And during that time, I usually didn't use an interpreter, and I would lip read and speak for myself and try to build that rapport on my own, even though by default I would typically use an interpreter. Well, one morning they happened to have an interpreter available with them for the first time, and it worked out really well, because even with the discussion and the questions and answers, I had an opportunity to fully participate. So most of the time I would only ask 1 or 2 questions, but then with the interpreter there, it opened up the communication. I was able to get more information. I had a longer, more rich conversation with them than I ever had before. And it took me a few days of reflection to realize that the cognitive load of just trying to lip read and understand the words that people were using and look for those communication strategies to connect with them really took the focus away from what I needed to pay attention to, which was my daughter. Cullan and Alex were talking, well, and Cori too, we're all talking about individualization and how the system approaches people. And, you know, as healthcare providers, we're system experts, so we need to create access in terms of a universal design perspective that will work with all of our patients to help them connect to us.
Thank you. There's a question in the back. We probably have time for like one or two more questions. No.
Hi, I'm Erin. My question was around the role as an employer. And so how, as I picture our emergency department, if I'm being totally honest, I don't picture a department that is accessible for a large variety of populations from the perspective of if I were to hire an employee. And so I guess my question sits around who's responsible for knowing when accommodations are needed? Like, who do we engage in that? I have some ideas, but at a very practical individual department level. And do you begin making those changes before you have an employee, or does that all center around an individual employee as they come on board?
I think that's a great question, and I think you are right that our departments are not well designed for patients with disabilities or employees with disabilities. You know, if there is an employee with a disability, when they get hired, they engage with whichever office, you know, at the institution to request their accommodations, and there's a process that happens there in terms of, you know, documentation of disability, and then kind of a negotiation back and forth in terms of what constitutes reasonable accommodations. And, you know, that's a whole other, we've done a lecture on that actually. So I think, you know, it's so variable because it really depends on the nature of the individual disability. You know, the employer has no obligation to provide accommodations that change the fundamental nature of the job. That's what's in the language. But there can, you know, many times that ends up going all the way to the courts if there's a disagreement on what the fundamental nature of the job or the fundamental nature of the program for a student might be. So ultimately, you know, you're right, it does tend to happen once there is that individual with a disability who is seeking accommodations. That's when people pay attention, and it would be great if we paid attention before that and created spaces that were accommodating for all sorts of, you know, types of disability.
I hear that from a legal obligation perspective. There's precedent to say that the resources of the entire company need to be considered when determining whether an accommodation is an undue burden. But you know, so typically the best practices I've seen from an employer perspective is that there's a centralized accommodation functionality through HR, through something else, rather than being done through each individual department sort of ad hoc. It's often a much less efficient way of doing things, but really it just depends on the company culture. And from a patient perspective, it's really important to have one point of contact for all patient interaction, because as a patient, I'm probably going to be going through multiple different departments, multiple different concerns, you know, through ER, through my interns, through specialists, and having to re-navigate that accommodation agreements or pipeline or whatever you want to call it really adds a lot of overhead to that prevents me from getting the health care I need.
I love, if I can add, do we have time? I love that we're pivoting to workforce issues. That's really my favorite topic right now. So thank you for asking that. I have a colleague, and she and I have done a lot of work looking at policies and procedures in terms of if they are welcoming or not to healthcare professionals in the environment, in the training environment, and their access. To add to to add to what's already been said, we need to think proactively and aggressively before the event happens. So in terms of a person with a disability even applying to the workforce, what about the workplace is attractive to people with disabilities? And that's a very long, detailed conversation. And it reflects the complexities of the disability community in general. I think it's important to engage people with disabilities as experts, to offer their expertise and their experiences when you think about what that environment could look like. If the environment doesn't look inviting, people with disabilities are not going to apply. And that's also true for medical schools and residency programs.
Thank you. So as we approach the conclusion of our presentation, we'd really like that our audience go home with a few of the following take-home points. Disability is an aspect of diversity. Ableism, or practices or policies that treat people with disabilities as less than human and using able-bodiedness as a default state. The implications of ableist language result in inadequate care, denied care, and poor treatment. Best practices in language and communication include using inclusive language, avoiding microaggressions, using person-first language, and use the person's preferred language. I'd also, of course, like to thank our panelists for their expertise as well as their transparency, and as not only as clinicians and providers, physicians, but even as people, making sure that we use, we're no longer using ableism as a lens through which we approach our patients and patient care, but seeing all of our patients through the lens of diversity, equity, and inclusion, and disabilities are just an additional form of diversity that we take into consideration when attempting to provide best care for our patients. So just as we usually think of things such as race, gender, sexual orientation, but disabilities are just an additional form of which we need to incorporate and take into consideration when we take care of our patients to make sure that we are practicing and delivering care through a lens of cultural humility. I use this QR code because I think it's really important for us to be proactive and to perpetually self-evaluate just as we keep up to date with the latest antihypertensives. Check in with yourself if you can and think of ways in which you may have interacted with patients with low vision, members of the deaf community, or people who are not able-bodied, and think of some of the things that you've learned in this presentation and ask yourself, have I changed or modified the ways in which I take care of our patients? Thank you so much for joining us this morning.
Thank you, everyone. Just to add to really quick for basic subtitling, if you didn't know this, the new PowerPoint, not the old ones, only the new ones, have an amazing ability to close caption. It's extremely accurate. I think it's better than what your iPhone even picks up. Whatever tech they're using is quite good. So that's actually was my MacGyver solution for our panelists. So I'm running my computer off of the current PowerPoints subtitling since the hotel only has the old one. But so it's something to keep in mind, and you can use it for your presentations at your workplace. And also Zoom has a pretty good closed captioning as well. So I highly encourage you to start just kind of making that part of your practice. It's really helpful for people. And a lot of times, right, people don't raise their hand and say, hi, I need this accommodation. So it's super easy if you just kind of incorporate it off jump. Thank you.